that we got this technology into the country, and it created quite a sensation in the lay press. However, I would say 14 years down the line, we have two of these MRIs now, that it was very slow in uptake as far as the medical fraternity was concerned. And even though, as we'll see, it has a lot of impact in spine, imaging of the spine and consequently the surgical indications, but I feel that now probably it's reaching a tipping point where acceptability is increasing, and so weight-bearing MRI, we do weight-bearing X-rays. Why should weight-bearing MRI not be done? Normally, patient will have pain when he sits or stands. When he lies down, the pain goes away. But we do MR scanning in the supine position. Why not in the position where he has the pain? And this was made possible by this equipment from Esaute. Very good looking equipment, open scanner, comfortable for the patient, where you can actually tilt the MRI. It's 7 tons, but it tilts seamlessly, and you could stop it at any level. We generally, for the spine, do it at 70 degrees, not at 90 degrees, so that the patient gets some support, because generally they start having pain when you put them absolutely upright. And, we detect lesions on MR, but questions still remain, especially when there are compression at multiple levels. Which ones are related to low back pain? Can weight bearing provide additional information? And what is the response of some anatomical structures to load? And further questions, pain on sitting, standing with a negative MR. Can we give something more? Post-operative persistence of pain? Can weight bearing provide some further information? Then increasingly, decisions on stabilization and use of hardware, as that has increased in the last decade or so, I think weight bearing MR becomes important. Even planning rehabilitation after surgery, and also in defining the difficult concept of what is instability. The additional benefit, of course, is that it's an open system, and for the claustrophobics, it's really a boon. If we look at literature, again, that shows acceptance over the years, more and more being published. And really what the ultimate message is, that upright MRI is superior to supine MRI for diagnosing degenerative spinal disease. So degenerative disease, it's really exceptional. This is how it looks like on supine, and in the weight bearing position, as we all know, the lordotic curvature increases, and that leads to its own increase of compression that we see. One is also able to do very high resolution, thin section imaging. Even though this is a permanent magnet, these are volume acquisitions that are done in the axial plane, and you can actually reconstruct them along the discs. Thin sections, 3 millimeters, obtained on a permanent magnet. For me, who was only used to high field MRs, it was actually a revolution at the kind of quality that was obtained. I've been doing MR for 37 years, and still I've been amazed with the quality that's, these are reconstructed along the intervertebral discs. Let's look at some cases, and as you can see here, this was case number 2, 2010, and sometimes the initial case is such that it brings home the advantages of a particular modality. This was a lady from Afghanistan who had had tubercular infection, L5S1 level, came back with pain, and a routine 1.5 Tesla MRI done at that time showed that there appeared to be reactivation of the disease, but there appeared to be no compression on the supine MRI, even though there was this signal alteration, but no compression, as you can see, on the supine. But when we put this patient in the standing position. Here again on the axial you see hardly any compression. But when we put her in the standing position, and this is done very rapidly, 1.5 minute series, not very pretty looking pictures, but what we saw was very dramatic. That and if we look at, compare the supine with the standing weight bearing MRI, you see that this disc material has actually squished out, causing marked compression, and also there's a little forward bending of the thickened ligamentum flavum at this level, causing marked compression, and that explained why this patient was okay when supine but had severe pain when she was in standing position. And if you see the height of the disc, how it changed between the supine and standing. This was a patient taken up for surgery, fixation done, and she did very well on anti-tubercular therapy. This is another patient, supine MRI, and look at the lumbar canal stenosis, the marked stenosis that you're able to see on weight bearing. So this actually is the difference between wondering what to do and then going ahead and operating, because the weight bearing MRI is able to give you the exact mild increase here as compared to supine, but yet subtle but clinically significant change which is seen on weight bearing. And you can see the quality of the scans is quite diagnostic, very acceptable, and these are routine MRI that has been done, not something which has been done for this conference. Radiculopathy, again another case where you see this is supine on L4, L5, and this is on weight bearing, where on the axial you can see that there's marked narrowing and compression of the nerve root here at the lateral neural foramen as the nerve root exits out. Instability and spondylolisthesis, what MR can show in addition to what you see on X-rays, is the compression that, so this is grade 1 becoming grade 2, and also showing instability and hence fixation which needs to be done. This is a case where you see anterolisthesis. This is supine, and look at what happens on standing. Not only is there anterolisthesis, but also forward buckling of the ligamentum flavum and marked compression. So a patient who would be on conservative management taken up for surgery. Again, another case, grade 1 to grade 2, seen very clearly. And this was a case, an MP who said after about sitting half an hour in the parliament, he would get pain. He did have a L5S1 disc, but that is not where the pain was. The pain was higher up in the lumbar spine. And you can see that on standing weight bearing, there is retrolisthesis of L2 on L3, and that actually was the reason for the pain. Again, you can see foraminal stenosis here, which is, typical teardrop shape you see at L2, L3, and you can see the foraminal stenosis. So the advantages that you get, not only the mid-sagittal, most of which I'm showing, but you can get images in both sagittal. And this is facet joint instability, which you can see. This is supine, and this is on weight bearing, where you see instability and posterior subluxation, which is seen. Now, it's even useful in the cervical spine. This is a case pre-surgery where it was an unstable C1, C2, and following surgery, there's not only space created, but we can also see that it's become absolutely stable. Cervical spine, one wonders, even the weight of the head is enough to cause an increase on weight bearing. In the cervical spine, you can see supine versus weight bearing, And again, post-operative, you can see this ligamentum flavum hypertrophy and forward bending, forward buckling, which becomes apparent after surgery on C1, C2 level. We can also do dynamic imaging, flexion, extension, all that can be done not only in the spine but in joints as well. But in the spine, it's relatively very easy. Metal artifact reduction, depending on what kind of implant has been used, you can see how nicely one is able to see the screws here, interpedicular screws. Again, another case showing the same. And this is, on the open low field MRI as compared to what you see on a 1.5 Tesla MRI with metal artifact reduction. In addition, in conclusion, I like to say that software that's available today does automatic segmentation of the image and the spinal canal. All the measurements can be done, 3D modeling, rendering can be done automatically, geometrical measurements done automatically, and also comparison between supine and weight bearing, which is done automatically using spine quantification algorithms, AI algorithms that are available. So in conclusion, I'd like to say, even though this technology has been available for about 25 years, I think the tipping point for spine surgeons is reaching now, and I see more and more spine surgeons adopting it. In fact, spine surgeons buying the machine and using it in their practice because it does make a difference. And I conclude by these words of Jack Welch, the legendary chairman of GE, who said, "Change before you have to." Since it's useful, it's not just technology for technology's sake, but it makes a difference in day-to-day imaging and in decision making. So change before you have to. Thank you very much.